Welcome, everybody, to Healthcare Rounds. I'm your host, John Marchica, CEO of Darwin Research Group. I'm really excited today. I've got my friend Aric Burke here, who is President and CEO of Atlas Healthcare Partners. And today we're going to be talking about ambulatory surgery centers and their impact on healthcare today and the impact of healthcare in the future. We've got a whole bunch of things to talk about. But first, I just want to say, Aric, thanks for taking the time today to spend time with me and our audience for Healthcare Rounds.
Well, of course. Thank you, John. Appreciate the invite and look forward to the conversation.
Okay, so I know you're an expert, but maybe the audience doesn't. So how about just give us a few minutes up front about your background and then what led you to being part of Atlas?
Yeah, sure. So been involved in the surgery center industry now for over 20 years, really going back to really the early 2000s when ASCs were probably having their first big wave of growth, and really started my career on ASC development. So working with health systems to plan out their ASC strategy, buy surgery centers, and then also develop new surgery centers, typically with physicians, which is a model that we still believe in and execute on today. And then I moved into operations with United Surgical Partners, moved to Arizona ultimately at that point, and then served as their market president for about 5 years in partnership with a lot of large health systems across the Western U.S., and then had the opportunity to start my own company, which is Atlas, really to initially partner with Banner Health here in the Arizona market, and then now with other health systems across the country, really helping them with their ASC strategy development and management.
I have to ask you this question. I love this question for you. As an entrepreneur, what was your growth rate like in terms of hiring from, let's say, year one to year two to year three, in terms of people?
Our situation was pretty unique, I would say, and probably challenging because of that uniqueness. But we had to go from 0 to probably 100 miles an hour overnight. And so, the Banner relationship was an amazing opportunity, but they wanted to grow fast in terms of really the management of their current surgery centers and then lots of new development of new centers. And so we took over their employees right out of the gates, like January 2019. I think that involved probably around 300 or 400 people overnight. And so as a brand new company, we had to stand up everything infrastructure wise, getting benefits and payroll and HR all in place. And looking back on it, I would have done it differently, but that's 2020 hindsight for you. And since that point, we've grown to now over 1,100 employees in about 5 years of operations. So from 0 to 1,100 has been an interesting experience, but I think we're getting the hang of it. So,
well, we'll get into the Atlas model here in a little bit, but I wanted you to just kind of stay general for a minute and talk about the ASC model, and in particular, why this is attractive to IDNs, who typically would have surgeries, of course, if those that have surgery centers, but might be having them in the hospital. What makes this, what is it? And then why is this model attractive?
Yeah, that's a great question. I think a great place to start. So, surgery centers really do fit the quadruple aim of healthcare, I think, extremely well. They're ultimately lower cost, more affordable care compared to the hospital setting, which we'll probably talk about quite a bit today. So number one, lower cost, which I think everybody in healthcare is trying to achieve that goal. They're very high quality. I think one of the benefits of surgery centers is that we do the same types of cases over and over every day. It's a very specialized, focused type of facility. And so I think that leads to very high quality outcomes, great consistency in terms of the care model. Patient experience is also very high because of that. surgery centers tend to be very convenient. They don't have to be on hospital campuses or even near hospital campuses. So, ideally the patients can be in and out in a couple of hours, and you can be doing pretty high acuity cases ultimately on a same day basis. And then the fourth is the physician experience. And I think there's a lot of, more that we could talk about related to physicians in this model, but their experience in an ASC is typically much better than in a hospital setting. Again, because it's a focused type facility, we do the same cases over and over. We don't get bumped for inpatient cases or trauma. And then we can really focus on the doctor's efficiencies. A lot of these cases can be done, again, very quickly. So doctors can be in and out. And then we're very focused on their equipment needs, their staffing needs, and their needs as a customer. So, I think the quadruple aim of cost, quality, patient experience, physician experience are all, highly aligned in an ASC setting, which is driving a lot of the, I'd say, growth and demand at this point.
Yeah, well, we were talking before we started recording, and didn't plan this, but I had an experience at one of your ASCs in Scottsdale. I had a shoulder procedure done. And I got to say, compared to being in a hospital, people were nice. I waited, I think, 10 minutes to go back and to get prepped. I was out of there inside 2.5 hours. And my wife came and picked me up. And so it was just overall, any kind of surgical procedure is going to be stressful for people, right?
Right.
And so I can say it's an N of one. As a patient, my experience was great. And I think it can't be overstated, the idea that in talking about doing the same thing over and over again, it's kind of like, what they tell you, if you ever have a procedure done, find the doc that does just that procedure and does lots and lots of them, right?
Exactly. Yep.
Because you want to minimize errors. And if they've done, 1 million angioplasties or 1 million, shoulder work like I had, you've got a better shot of success. And that's what the data shows. So I want to, you mentioned something about doctors, and I think this is really important for you to touch on. And that is, what is the role of ownership, and what are some models maybe that have been tested and tried that are different from the Atlas model? But I think it's important that you go into a little detail here.
Yeah, no, for sure. And I'm glad you had a good experience in the surgery center setting. It's good to have the customer testimonial. I think just to add to my previous answer, I think the reason ASCs, I think, are really, I'd say, critical going forward for health systems as they build out their integrated delivery network is that, it really gives them that outpatient side of service. I think care is being shifted out of hospitals, largely due to payer pressure. I think all payers, government and commercial, are looking for lower cost sites of service, and not just in surgery, but surgery happens to be one of the more expensive types of services. And so I think the payer pressure is probably only going to increase. And this comes back to the employers obviously shopping around for insurance for their employees, and also the individuals, as consumers, as patients. I think people are realizing that they don't have to go to hospitals for care. And, when you compare the co-insurance and the deductible that you pay for the exact same procedure in a hospital versus a surgery center, it can be, 1, 2, 3 times as much. And so if your co-insurance deductible is largely on your shoulders, you're going to shop around and look for a better option. And so
Sure.
I think that payer pressure is absolutely, one of the drivers. I think, additionally, the physicians, ASCs going back now, they really have been around since the 70s. Interesting kind of note, our Banner Surgery Center down at the university campus in downtown Phoenix is the kind of successor of the original surgery center in the United States. It was originally across the street and now on campus. But that was in the late 70s when this model was first created. And it was created by physicians. I don't think that's a coincidence. Physicians were looking for a lot of the benefits we're talking about. But as it's evolved, I think the government, has carved out safe harbors from a, regulatory standpoint that allows certain physicians, to be eligible and legally approved investors in surgery centers. And so when you think about doctors and what their pressures right now are, that staying in private practice is challenging. Reimbursement rates are going down for physicians. I think the regulatory burden is high and potentially increasing. So it makes it harder and harder to stay, I'd say, viable in a private practice. And surgery centers are a great investment for doctors, because if you think about it, they're doing the surgeries anyway, the procedures. And by being part of a surgery center, they can legally invest into the surgery center business. And the way it works, just from a kind of financial standpoint, is the physicians will be paid a professional fee for doing the surgery, regardless of site of service. So hospital, surgery center, clinic, they get paid the same professional fee for all intents and purposes. But what's different is in a surgery center setting, they get to participate in what's called the technical fee or the facility fee. And so essentially the surgery center bills for everything besides the surgeon's time and the anesthesia time. So the surgery center provides for the facility, which includes the ORs, the equipment, all the staff, the nurses, the techs, the front office staff, all the supplies and implants, really all the other expenses necessary to provide that surgical procedure. But as you basically take your income statement for a surgery center, revenues coming in, expenses going out. If there's profit, which there should be in a well-run surgery center, then the physicians get to participate in that profit based on their ownership percentage. And so ultimately it creates an additional income stream for surgeons, in addition to their professional fees. And I think that's very attractive to them. And then if you talk to surgeons who are involved in surgery centers, they'll tell you probably equally as important to that investment return is just having some control and input over where they operate.
Sure.
Our model and a lot of the other models allow for physician governance and really a lot of decision-making involvement in the business itself. Everything from, what service lines do you want to cover? How do you want to, what's the right size of the facility? All the way down to, the block time being allocated to different physicians. And so the more involvement, in my opinion, the better from the doctors, the more engagement, the better. It leads
Sure.
to better outcomes, better financial performance. And so there's just a lot of benefits. And I think because of that, physicians for a long time have been driving this shift of care out of the hospital setting into surgery centers. And it's just aligned incentives, at the end of the day. They get to participate in governance, operations, financial returns. And so I think you'll see more and more of that. Additionally, I think, there's this improvement in technology and technique. Cases that, 20 years ago, like total joints, people didn't think would be appropriate for an ASC are now done every single day in an ASC. And
Right.
there's other examples of that. Cardiovascular is probably the most emerging. And so I think just creating more and more opportunity to do things outpatient, and doctors are taking advantage of that opportunity.
So I know this is a kind of a specific example, and as I said, we'll get to Atlas in a moment. But how do you deal with sort of competing incentives, competing priorities when you have the Atlas model, or in this case, Atlas is really running the show. You have an ownership component from an IDN, in this case from Banner. And then you have an ownership component or a buy-in component, or however you want to call it, from the physician side. How do you keep all of those aligned? And do you end up having okay, this week the loudest voice is the banner people, and this week the loudest voice is the physician steering committee or whatever you would call it. How do you deal with all the fingers in the pie?
That's a good question. I think the good news is, I think if you align everybody's incentives and roles and responsibilities, it can work very well. And I think ultimately all parties, the physicians, the health system, and the management company, I think can bring a lot of value to the table. And if everybody does their part, then it really is kind of a win-win across the board. And so, what I mean by that is, essentially in our model and other models, I think there's a lot to do to operate the day-to-day of the facility. It's fairly complex. And I think, some physicians choose to, develop and manage their own surgery centers. But I do think when you kind of look at the time required and ultimately the expertise required, physicians are full-time doctors. They've got a lot on their plate running their practices and taking care of patients. And I think the complexity of the ASC business, ASCs can make a lot of money if run well. They can also lose a lot of money if not run well. And so there's quite a bit of risk involved financially. And from a regulatory standpoint, these are facilities that are licensed by the state. They're certified by Medicare. In our case, they're accredited by Joint Commission. And so there's some pretty significant regulatory requirements that also adds a lot of, burden and expertise requirements. And so, essentially what we do is we are kind of that glue or that buffer, that comes in on a day-to-day basis, takes responsibility for running the center. And then the physicians come, bring their patients. We view that the doctors are the customers, whether they're investors or not. So providing them a great service experience, first and foremost, taking care of their patients is really the job number one. And then the physicians that want to be involved in the governance and operations, our model is to typically have a board of managers. Physicians, the best model, in my opinion, is the physicians elect essentially their board members to kind of manage on their behalf. And so ultimately there's probably 3 or 4 doctors that sit on the board and help to vote on and make decisions of the business. Once in a while there's a big kind of issue that needs to go to the full membership, but in our model it's pretty well, I'd say, managed by the board. And then we bring the health system onto the board as well. And we find that there's a lot of opportunity for collaboration and different opportunities to connect the dots is kind of how I look at it. The health systems bring a lot of primary care doctors, insurance products, the entire health system delivery network. And there's ways they can connect that to the surgeons, whether they're employed or independent, which should hopefully make everybody busier and more successful. And then the health systems in our model ultimately are the majority owners of the surgery centers. And so they're branded under the health system brand, which I think brings a stamp of quality.
Sure.
Gives patients something that they're familiar with. And also the managed care, I think we team up with the health system to find the right price point, from a reimbursement standpoint. But ultimately, these are surgery centers under the health system contracts. And so we're able to negotiate contracts accordingly. And that brings value to the business, that the physicians benefit from. And so we really look to try to articulate, what everybody brings to the table and then make sure everybody's doing their part. And I think when that occurs, the kind of 3-party partnership is very successful.
I can see how it would be challenging, though, but pulling all those folks together. One of the things that I think brought us together for this conversation was an article that I saw in Becker's that talked about an increase in focus and I guess a number of ASCs looking to really expand the cardiovascular offerings. So I mentioned I had a relatively simple shoulder, not a replacement, but shoulder procedure. You had said, now total joint is kind of you do it every day. So I'm curious about what this trend is and moving in cardiovascular. And maybe you could also touch on for the layperson, like what are the rules, or how do you know what you can do in that ASC environment versus what really needs to be done in the hospital?
Yeah, no, that's a great question. So I think this is applicable to probably all service lines or specialties. But cardiovascular is probably the most quickly, I'd say, emerging from an ASC standpoint. There's just a lot of shift out of the hospitals into ASCs in this service line. It's kind of new and different, I'd say, versus the others. And really what's driving that is a couple things. One, Medicare, quite frankly, CMS really does drive a lot of shift. I think they're looking at what potential savings look like for both Medicare and Medicaid reimbursement, and they've identified that ASCs, as again licensed by the state, certified by Medicare, accredited by Joint Commissioner or something along those lines, provide really a high quality facility for the patients. So there's kind of a quality, I think, aspect to it. And as a result, every year Medicare goes through and says, what CPT codes cases should be ASC appropriate. And they've been adding, through the years, lots of new codes to the ASC approved list. The commercial payers typically, I'd say, piggyback off of that list. There's some examples where the commercial payers will approve cases that are not on the Medicare list. But in general, the Medicare list is kind of the standard, list. And that just tells you what cases are appropriate. You then have to look at the acuity level of the patient, obviously. And so we have admission criteria that we work through with our health system partners, with our physician investors, in terms of what's appropriate from a medical standpoint. Also, obviously, deferring to the physician judgment on that. There's a lot of good evidence-based data out there. And then, you kind of look at the comorbidities of the patient, the acuity level of the patient, of the case, and anesthesia required. And then ultimately there's a pre-assessment testing for every patient that determines whether they're an appropriate ASC candidate or not. If not, then they remain in the hospital. But, I think for most service lines, we see that of an ASC approved code, 80, 90+% of the patients can be done safely in an ASC. So there's very little, honestly, that is, required to be done in a hospital at this point. It's really the really high acuity, comorbidity, intense ASA 4 type cases.
So reading between the lines, maybe, is it, did Medicare approve a bunch of, new CPT codes, and were they the driver? I don't think a lot of people understand, there's always this, just kind of going back quite a few years, but talking about Medicare for all, and people just said, oh, it's just such a horrible idea. And maybe, but so much of what Medicare does, so much of their regulations, whether it's, around, hospital payments or ACOs or ASC, it seems like they're still in the driver's seat. That, as you mentioned, there may be sometimes on occasion a private payer or a commercial payer will say, all right, we're going to reimburse for something that Medicare doesn't. But more often than not, it's completely the other way around, with the commercial payers kind of following what Medicare does. Right. So was it one of those situations, Aric, where like they just said, all right, now you can do all these procedures, and then the ASC market, everybody just gloms onto that and says, all right, let's go get that share?
Yeah, exactly. I think with cardiovascular, it's been a little unique for 2 reasons, or maybe more. But one was physicians, again, as entrepreneurs, and I think change agents, really identified years ago that they could be doing, cardiovascular type cases outpatient. And so they started doing them in their offices, office-based labs, OBLs, I think have been around for a while. And I think the difference was that, and Medicare initially approved some cases there. I think the issue was that those facilities were not licensed at the same level as an ASC. They were office-based labs. They're not ASCs. And so it did limit, I think, some of the oversight and probably, quality in those facilities. And then they were typically not Medicare certified at all, or not at the same level, and they weren't accredited. And so I think Medicare kind of realized that, yes, these were cases that shouldn't be in a hospital necessarily, but were probably not right for a true, clinic at this point. And so they wanted something in the middle from more of a quality and oversight standpoint, and realized that ASCs are kind of the perfect landing spot for it for those reasons. Additionally, I think that physicians, either intentionally in some cases or unintentionally, we're running an out-of-network model on the commercial side, which was ultimately driving up cost. And so the commercial insurance companies also kind of caught on to that. Obviously, it was getting expensive. And so they wanted to shift those cases out of the office-based labs back into the ASCs on an in-network basis. And so I think that all kind of just came together and, landed that ASCs were the most appropriate site of service for some of these cardiovascular cases. And then the other major factor is the state. So even though Medicare has made this determination that cardiovascular cases, are safe and appropriate in ASC, and they've determined the payment methodology, certain states, it's still very interesting right now. Of the 50 states, there's probably half that are still not supportive of doing all of the different types of cardiovascular cases that are Medicare approved in an ASC. So those states then need to go through their process to determine if they need to amend their licensure requirements. And so we're starting to see that trickle in a little bit, but Arizona happens to be, one of the more, I'd say, I don't know what you want to call it, free market states, at least from that standpoint. And, these types of cases have been allowed in Arizona ASCs for a long, long time. And so you've seen this migration in Arizona happen pretty rapidly, whereas other states, it's not even occurring yet. So just very interesting, the dynamics across the country.
So I'm familiar with the quality incentive programs for hospitals as well as for ACOs. And then, of course, physician offices have their own. What kind of quality incentives or quality measures are laid on the ASC specifically, and if any, and if so, are there the same kind of carrot and stick approach with respect to reimbursement in the ASC setting?
Yeah, it's a really good question. It's still early days in terms of that type of model. Medicare does have some requirements for safety and quality reporting. For the most part, it's there's a penalty if you don't report. They haven't really transitioned fully into an HCAP model where they're paying you as much based on the performance results. I think that's probably coming, and it probably should be coming. They're just recently, I think 2025 is the first year it's required. But patient satisfaction or patient experience wasn't required in an ASC like it is in hospitals. That is now changing in 2025, where you do have to have a patient experience survey, and you've got to report to Medicare on it. It's still not a carrot or stick necessarily. It's if you report, you're fine. I think over time you'll see it probably match up more with an HCAP type model where you're paid for performance, but it still hasn't really occurred yet. We think there's a lot of benefits of tracking our safety data, quality data, patient experience data proactively, whether it's required or not, and then taking that to the commercial payers, especially showing that this is ultimately a lower cost setting, not just from a reimbursement standpoint, but from a quality and outcome standpoint, which I think is the real goal, and that it's a very positive member experience, for the insurance companies that are trying to grow their membership. You want the facilities that you have in network to be a good experience for your members. And so we proactively, are very focused on data and making that case that this is a very high quality, high experience in-network facility for the insurance companies.
That's really smart. I mean, when you don't have that sword of Damocles hanging over you from Medicare that you must submit, you must do this in order to be, that if you're out there competing for the business with some of these, with the commercial folks, that you can actually demonstrate that level of quality. Is that sort of table stakes? Do you find that your competitors out there, that this is kind of standard fare, that other ASC companies are doing the same thing, proactively managing and sharing their quality data?
I think so, but it's interesting. Even with the commercial insurance companies, they haven't quite figured out how to use that data either in terms of carrot and stick. I think there's a few maybe more proactive companies that are trying to negotiate either savings or kind of risk-based contracts. But what we found is a lot of the insurance companies aren't really ready to administer that for surgery centers yet. And so I think it's a matter of being prepared, using it to contract and hopefully get the right reimbursement. But then in the future, it's probably going to be more value-based contracting, and being prepared for that is important.
One question that has been top of mind for me is that we work with a lot of pharma companies. Anybody who listens to Healthcare Rounds probably knows that by now. And there's been sort of a long-standing, and I think we've talked about this, but long-standing approach by pharma trying to work with IDNs on projects and partnerships and other things. In the ASC world, and this is probably out of your scope of thinking just in general, but in the ASC world, do you see that there might be room to partner with a Pfizer or Merck or any one of these companies? I'm thinking like, let's say they have a treatment for heart failure that they want to make sure that once a patient gets out of this cardiovascular procedure that they're on the drug, or a pain medication, or any number of comorbidities that might be present. I'm just trying to think if it makes sense to kind of like work in the same sort of way that Banner might be working with the J&J or one of these big companies, if it makes sense to do that at the ASC level. Have you thought about that at all?
Yeah, I mean, we have. It's interesting. I mean, you see a lot of it with the device companies,
Sure.
Rikers, the Arthrexes, J&J to some extent. I think when it comes to the pharmaceutical side, it's, it is challenging. It comes back to that reimbursement, model of, it would have to be reimbursed differently or at least be included under the Medicare CPT methodology. And then once it is, then the commercial payers have to, if it's unlisted CPT codes, generally you don't get paid very well. So it has to become a listed CPT code. And then from there, get the right reimbursement with the commercial payers. And so if it's something like along those lines, there's certain examples that have made their way into the ASCs, but it takes a while to get through that approval process and get the reimbursement in place. Unless you can make the case, that you're going to lower the cost of the surgery centers by substituting something and saving the surgery center money, then I think there's, a lot of, I'm sure, interest in that. But we haven't seen a ton of, I'd say, outreach or coordination with the pharmaceutical companies as much as the device companies.
Yeah, well, obviously, I mean, the devices, they're used in the process, right? And I could see, the procedure that I had done was, sort of the PRP and the exosome. So maybe the exosome companies might be calling on the ASC. But I'm just wondering, again, back to the quality, if there were some logic. So there's the reimbursement side of it, almost like a formulary, is our drug approved?
Right.
But then there's can our drug ensure that the surgery is successful, or to your point, that it's saving money? That's something about the entry. We worked with a company years ago that had a new product that was like and I don't want to throw anybody under the bus, but I don't think they quite made it, so I'll just say it. it was drops that you put in the ears when kids had ear surgeries, for very common surgery when kids are young. And the idea was, you would put these drops in during the surgery, and then that's it. You could forget about it and would take care of things for 10 days thereafter, or however many days, compared to putting drops in your kid's ear for 3-4 times a day for 10 days after the surgery, right? Mm-hmm. So a very compelling, potentially from a quality standpoint, but this company priced the drug so high that the value, I can just imagine the ASCs or the IDNs are looking at formulary. We're saying, amoxicillin is fine.
Right.
To add this cost to the procedure, and then there's the whole thing about CPT codes, and we're going to get reimbursed and all of that. So that was not a good example of a good value proposition, and they didn't make it. I don't think, and a lot of that had to do with cost. But I'm always just kind of looking for that angle. Is there a way to kind of bring different partners together to make healthcare better? And I'm just sort of more familiar with the pharma world than I am on the device side.
I think it probably is. I think it's, I encourage the pharmaceutical companies to kind of, understand the ASC model, right? Like, is it going to be something we can get paid for on the reimbursement side, revenue side? Or is it something we can, use to reduce our costs? And I think your point about improving outcomes is very valid. But I think you're going to have to then say, again, does that, from an ASC business model standpoint, how does that translate to the bottom line? And think through that with the ASC companies. But I think we've seen a lot of just interest. I think the bigger companies like J&J and Stryker and Arthrex are really putting a major focus on surgery centers because the cases are moving out of the hospitals, and they want to ensure that they retain that business as it moves to ASCs.
Is it the same? Now, really getting into the weeds here with sort of the selling model, but is it similar in the sense that my sense is in the device world that the whole idea is to have a physician champion, right? And then that physician champion can drive your Stryker device, your J&J device, whatever it is. Does that hold the same water in the ASC model?
It does, with the kind of unique twist that the doctors are now owners. And so some of their loyalties change a little bit. I think they'll still bring their friends and their reps to the surgery center. But when we, our job again is to show the data, make recommendations. Doctors ultimately make the decisions. We don't tell them what to use, but I think by putting things side by side, and we can kind of show, here's what your peer group is doing for the same case in terms of implants or even, medications. And then what's your cost profile kind of on a percentile basis versus your peer group. And if they're owners in the center and they're focused on getting a distribution check, a lot of times they'll either help us negotiate differently with the reps and the vendors, or they may make decisions to use something different. I think when they're paying the bill, they think about it a little differently.
Yeah. So we're running a little bit over, as I expected that we would, but I want to talk a little bit about the Atlas model, and maybe if you could, you don't even necessarily have to name a competitor, but compare the work that you're doing in the model, the inclusive model with physicians and all of that, maybe to a different kind of model and what makes you different.
Yeah, for sure. Thanks. I think what we're trying to do is really be that solution and that trusted kind of advisor partner for the large, not even necessarily large, but the not-for-profit health systems. I think everything we've talked about today, sounds like bad news for the health systems. All their revenue from doing surgery is very quickly, shifting out of hospitals and is at risk. That really hurts their margins. And so, I've found that the health systems need somebody they can turn to. Your choices essentially are let it go, like lose it to the competition or to the market. That's not a good option. Try to do it yourself. And this is really interesting. A lot of health systems are struggling right now with, surgery is something we do in the hospitals. It's a core competency of ours. Right. We should be able to do it in an ASC as well. And so there's kind of this fork in the road that a lot of them come to and say, should we just stand up our own ASC division and manage our own ASCs? Or do we really need a management company partner? And I think, Banner's a good example. They tried to do it themselves for about 10 years. I think they would tell you it didn't work, in all regards probably. And they came to the conclusion they needed a partner. And that's really what a company like Atlas is here for. And so we take, our approach is to be very strategic and almost consultative on the front end and say, what's your IDN strategy ultimately? And how do ASCs fit into that strategy? But I view it as connecting the dots, right? Like you don't want to lose that business. If it's going to shift outpatient, you still want to retain it, or at least a share of it. And so I think having an ASC network is critical. And we're seeing more and more health systems now prioritize that. And so when I say network, it means where do you need to have surgery centers in your community from a geographic standpoint? And then what kind of surgery center do you need? Like we've talked, they're not all the same. Some are multi-specialty Swiss Army knives that do everything. Those are probably more appropriate on campus or very close to campus. But then there's the community-based, ortho centers that can be anywhere, the GI centers, the pain centers like you went to, cardiovascular centers. They don't necessarily have to be tethered to a hospital. And so you want to have that kind of network plan of, again, where do you put them? What kind of centers do you need? What's the capacity that you need? If you think about the cases that are in your hospital now, you don't want to overbuild, but you also want to have enough capacity. And that's where partnering with doctors just makes a ton of sense. A lot of our growth has come from investing into existing surgery centers that doctors developed. And we can come in and, there's a liquidity event for the doctors that can be pretty attractive when they sell ownership. And then we come in and provide some synergies and some benefits like we talked about. They stay owners, they just sell off some of their ownership. And so that creates, more speed to market for the health system, more capacity. And then ultimately what we try to do is, help the health system with what's your physician alignment strategy and what's your service line strategy? Because ASCs are a perfect, I'd say, complement to both. We view that there's really 12 major service lines that are ASC appropriate with lots of subspecialties underneath. And so there's very few things that, procedure-wise can't be done in an ASC going forward. And so how can we help to augment your strategy, grow your service lines? It should be not necessarily about cannibalization and losing cases out of your hospital as much as, growing your service lines. And, a lot of health systems have an employed surgeon model, but they also, I think, rely also on having independent and community relationships. And ASCs solve both. I mean, they're great alignment for both. A lot of our partners like Banner are allowing their employed surgeons to invest in the surgery centers. And that's
smart.
Yeah, it is. It really is. A lot of health systems struggle with it, but it helps them recruit surgeons in the first place. There's a very competitive market for talent out there in all probably, industries, but recruiting surgeons is very competitive. So if you want them to join your medical group, you need to make your case, right? And so having a surgery center investment is very attractive for a doctor. And then we've seen that it increases retention. Doctors are more likely to stay in the medical group, stay in the community. If they have an ASC investment, they think twice about, leaving. And then on the independent side, we're big proponents of doctors staying independent, and ASCs can help them do that. So it kind of checks a lot of boxes for health systems or along the lines of having the network, keep the care ultimately in your IDN, align with doctors, grow your service lines. And we can help them with the analytics around, how do you prioritize it? What's your revenue forecast look like? What's your, cash flow and earnings forecast look like? What is coming out of the hospitals? But in a lot of cases, there's higher acuity cases that are backlogged in the hospitals that they can backfill the ORs with, which means that they're not really losing anything. They're just doing things in the right side of service. And so that's really what Atlas tries to do, is help them through the strategy first. And then once the strategy has been developed and approved and capitalized, then we can go out and execute on it. We're the 24/7 team that does this, solely and focused. Whereas health systems have so much to think about in their IDN, we take this one headache off their plate, and they hold us accountable, obviously, for execution.
Of course.
But we go and execute, buy centers, build centers, manage centers on their behalf, but they can still brand and have majority ownership on. In our model, they're not just majority owners. They also have governance control and financial consolidation. And, I think when you contrast it to the other models that are out there, our model is much more focused on the not-for-profit health systems being successful. I think that they need to remain viable and, strong. And this is a way of doing that. And then I think it puts the doctors squarely, in a leading role in the individual surgery centers that can then work in a nice way with the health systems from a, alignment standpoint. So I guess I'd summarize Atlas as we're trying to be very not-for-profit, focused and friendly, help them be successful. And then when it comes to surgeons, make it a great place for them to work, a great investment for them. And I think it's kind of a win-win for everybody.
I don't want to get too philosophical on this, but it makes me wonder, sort of what are IDNs good at? Because in this particular scenario, and I think the physician involvement for me is what's the real kicker, that if I have skin in the game, and, as you said, in the example at Banner, where they're allowing employed physicians to say invest, I think that's really, really important. And it's a key distinction. But, on the one hand, and you don't need to comment on this, Aric, but I'm just like, on the one hand, say an IDN becomes more sophisticated, more advanced in all the different ways that it can deliver care. And the most advanced, let's say maybe where they are also managing the insurance component or have the risk, right? But as we start getting into all of these different areas, you find the one glaring example that I always think of is home healthcare. And, the IDNs getting into that business and then realizing it's not like a business that they really do or understand, and then kind of divesting those businesses, or following a model that's kind of similar to yours without the physician ownership involvement, which is, working with an exclusive provider to run the home health component. When they have really gotten into the retail clinic world, a lot of them go the Walgreens or have gone the Walgreens route with partnerships, gone the CVS route with partnerships, gone the Rite Aid route with partnerships, gone the Walmart, kind of dabbled in there. We've written about these over the years, and kind of recognizing that maybe we don't know retail as well, or the, typical doc in the box kind of visits. So I don't know. It's an interesting question that, as on the one hand, IDNs want to have complete coverage of all the different ways that a patient, kind of cradle to grave, all the ways that a patient could need care. But at the same time, a realization that the delivery of those services can be so different. If you're talking long-term care facility, I know some people are listening right now going, duh, John, we like, oh, that's some incredible thinking that you've done there. But, as we're looking to the future and looking to see, well, what's going to happen with these IDNs, you have the Kaiser and Risant and Geisinger and Cone Health and all these mergers happening in the value-based world. It just kind of makes me wonder, if they're trying to bite off in some of these areas, things that they just can't chew, and so therefore need partners. I don't know. I think I should just end this sentence here while I'm ahead. And if you have any final comments on the IDN relationship, please go ahead, Aric.
I personally think you're spot on. I think it's really hard to be good at everything, and it's expensive to be good at everything. And so I think in our niche, we bring that expertise and that infrastructure that they don't have to recreate, right? It's you put that on your P&L as overhead to build up your own Atlas or your own ASC division. It's expensive and there's execution risk. It may not work like we've seen with Banner previously. Mm-hmm. And so I think a lot of health systems are realizing that and saying, look, we got to scale, but bringing in partners who are good at what they do is a good way to scale and retain at least a piece of the business in a lot of these different areas. So I think you're spot on. And I think it's really hard to be a master of everything and, execute on it all at the same time.
Well, I mean, and the trend is, right, we don't want people in the hospital.
Right.
And that's been the trend forever. And so these IDNs looking for other revenue streams and other ways to make money. And so if that other revenue stream is through surgery or through surgery centers, but they're not competent, or they can be competent faster by working with a partner and that kind of thing, it just seems to make sense. So before we wrap up, Aric, what's ahead? What do you see ahead for as we're looking at this ASC market and you put your projection glasses on? What do you see happening over the next 12 to 24 months?
Yeah, I think it'll remain very hot in terms of growth and demand, just for all the reasons we talked about. I think the new and different thing is the health systems really, I think for the first time, going all in on surgery centers. I think there'd been a lot of hesitation, from health systems because it was viewed as competitive, and they in some ways were just trying to ignore maybe the the writing on the wall. But I think they're now shifting it, and we're in a lot of conversations with health systems across the country, and they're telling us that ASC strategy is either our number one or number two priority. We need to figure it out. We need to be in the game versus losing out on the shift. And so I think we'll continue to see it's competitive. There's a lot of people jumping in, and I think it'll remain, pretty high demand for at least the next couple of years.
Yeah. I mean, to me, getting primary care right and getting surgery right are two major priorities and major thing for health systems that they're trying to figure out. And I think to some degree that other people are trying to figure out as well. Mm-hmm. Walmart was in, now they're out. Who knows whatever, if they're going to be back in some other way. Right. But really trying to get at like how do patients enter the system and how do we care for them in these low acuity settings. And then when they're in the system or adjacent to the system in, larger problems, larger issues that require surgery, how do we handle that? Those are two big revenue streams for these organizations, and they've got to figure out how to get it right. So, Aric, thanks so much. I feel like we kind of scratched the surface and we've been talking for almost an hour. So I really appreciate your taking the time, and hope to that you continue to have really good success with Atlas. And by the way, if anybody needs to reach you, what's a good way to reach out? What's the best way to get a hold of you?
Our website is atlaszp.com. And I appreciate your time today and having us on your show and all the success you're having with Darwin. So talk soon again, and thanks.
Sounds great. Thanks, Aric. Really appreciate it.
All right. Take care. Thanks.
Take care. And that's a wrap for another episode of Healthcare Rounds. Our guest today has been Aric Burke, founder and CEO of Atlas Healthcare Partners. I'm John Marchica, CEO of Darwin Research Group. And here's where every time I remind you, please rate, review, whether you're watching us on YouTube or listening to us on Spotify or Apple or wherever. Please be sure to follow us, rate and review us. And thanks. And see you next round. Take care.